I'm Guri Sandhu. I'm an ENT surgeon here in London. I work principally at Charing Cross Hospital. And I have an interest in problems related to the voice, airway, and swallowing. So consequently, I'm a laryngologist, and I'm also Professor of Laryngology at Imperial College. So we're looking at patients with a unilateral vocal cord palsy principally. And these are patients who've perhaps had surgery on the neck, either thyroid surgery or carotid artery surgery, sometimes thoracic surgery, or they've had a cold or flu and they've had what we call an idiopathic vocal cord palsy, and they're left with a weak, breathy voice. Now, depending on how the injury came about, and if it's from surgery, then we really need to know what went on and whether the injury is likely to be temporary or permanent. Because if the injury is temporary, then even if it's permanent, you can consider injection augmentations to restore the voice for a period of time while you either monitor or you make some definitive decisions. Alternatively, if you know that the nerve injury is permanent, then you can consider one of two things, really. One is some kind of permanent medialization, which usually means an implant. The other option is to do a non-selective re-innervation of the recurrent laryngeal nerve on that site. Now, this second technique is a good technique, but it does mean a period of waiting of 6 to 12 months before you get recovery. Whereas if you do a medialization thyroplasty, then the result is immediate, if you like. And this is one of the issues that the voice implant addresses. So I've done a lot of thyroplasty procedures in my time, and I used to fashion my own implant out of a silicone block, and it became a bit of an art. But even after, I've been doing this type of surgery for nearly 30 years, and it used to be the case that you would do it under local anesthesia, you would put an implant in, you'd put a camera in the nose and check, you get the patient to voice, you take the implant out, you refashion it, and you do this sometimes 4 or 5 times to get it just right. And then by that time, you've got some soft tissue swelling, and your appreciation of the correct position may be artificial in that a few days later, there may be reduction in the swelling, and then you end up with a gap on phonation. Also, you've got to bear in mind that after an injury, there is a tendency for muscular atrophy to continue. So when you see the patient with a shortened lateralized cord, you don't know whether more muscle is going to be lost from inside that vocal cord, and you end up with a gap 3-6 months later. So if you do an implant, then it used to be a case where perhaps 1 in 3 cases at some point you would end up making an adjustment in the implant or doing a little injection on the opposite side to close a gap that becomes apparent later. And the big plus point of this implant is that you can adjust it in the clinic setting. Usually with ultrasound guidance, you can get a little needle into the injection port, put a camera in the nose, and make any fine adjustments down the road. And the other great advantage of this implant is that it really is a paint by numbers type of procedure. It is measure here, cut here, window here, this size implant. It's almost like orthopedics. It couldn't be easier. So I think it lends itself to anyone who's comfortable doing any kind of procedure on the larynx through an external approach. Well, learning curves come down to the individual. Most surgeons who've been practicing for a while will have their hand held for the first 1 or 2, and then they're off running, and you just get quicker at it and more comfortable doing it. Some people, it will take a bit longer. But the learning curve is relatively short because you just stick up the chart that is provided and just follow the steps. Well, it revolutionized things. Some patients are quite emotional because, they've struggled with their voices for some time. They may have had injections, etc., without repeatable results. And to suddenly, be able to go free and voice and socialize their isolation ends, and most of them are very grateful. So my approach is this a temporary or a permanent injury? If you're unsure, then do an injection and wait. Offer the patient choices. They may want reinnervation, or they might want a more straightforward approach. And I have a low threshold for doing a voice implant now because it works so well and it is so straightforward. And unlike the old days, as I said, where you sometimes needed to go back and adjust your implant, that meant another cut in the neck, taking the old one out and putting a new one in. You can fine tune this down the road. It's very straightforward. One caveat is it can be tricky to hit the port, and I know a lot of my colleagues learn to ultrasound themselves and try and train themselves to find the port and inject it. I think you need to find an ultrasonographer who is really, really good at this. And I've got lucky. I have someone who's really good at this, and he pretty much hits it every time. So he finds it, puts a needle in, says, off you go. I do my nasendoscopy, put the camera down, have a look, and then make the adjustment there and then. It takes no time at all. So it's very straightforward in that sense. I have no negatives with respect to taking this type of surgery on. All I would say is you've got to get agreement. If you're doing it in the NHS, you've got to get an agreement from your management, because each implant costs and it will cost the department. Similarly, I always get patients to check with the insurance. Many of the insurance companies, not all, but many will agree to pay for the implant. So it's becoming quite straightforward. The other thing to bear in mind is that the company is very supportive. They will turn up on the days that you want to do the surgery and either sit quietly in the corner or guide you, hold your hand, whatever you want. So they're very helpful in that sense. They were excellent. If all things were that easy, they're always there. They're always there to help. They're always there to advise. And if they can't, they can often call someone who can. And so it's a premier service. I have nothing negative to say. I see its growth. I see more and more people taking it up because it is so straightforward. And, it's always worth approaching a colleague who's done some to go and watch them do it before you do it yourself. Because even though there is plenty of support from the supplier, it's always best to see one done first and then to take it on. My thoughts going forward, having done this for quite a while now, I have a slight concern that there is a tendency for the saline to dissipate out of the balloon, so you might need to do adjustments a year or two later. I say they're relatively easy to do, but I don't know if this is my perception or this is a reality. So in that sense, just bear that in mind. The implant seems to work much better in men than it does in women. Now, I don't know if this is a feature of women or whether it's the size of the larynx or the design of the implant, but just anecdotally, I get much better results in men than I do in women, even though the procedure is very similar. So I don't know what that relates to, and it may just be a gender difference. Other than that, I just imagine that more and more people will take this up because it is very easy. It's much, much easier than the old-fashioned do-it-yourself thyroplasty.